Med History.
Quincke's edema is an acute disease characterized by the appearance of clearly limited angioedema of the skin, subcutaneous tissue, as well as the mucous membrane of various organs and body systems. The main causal factors are true and false allergies, infectious and autoimmune diseases. Angioedema occurs acutely and passes within 2-3 days. Therapeutic measures for Quincke's edema include relief of complications, restoration of airway patency, infusion therapy, including C1 inhibitor and aminocaproic acid in hereditary edema, administration of glucocorticoids, antihistamines. In 1882, the German general practitioner and surgeon Heinrich Irenaeus Quincke studied acute angioedema of the skin, and the condition was named after him. Prevalence. Allergic and pseudoallergic angioedema occur in every second person with urticaria. Angioedema can occur at any age. The World Allergy Organization notes that urticaria and angioedema affect up to 20% of the population. According to her estimates, about 10 to 20% of people have angioedema at least once in their lives. In the United States, emergency departments register more than 100,000 visits per year with angioedema. From 1998 to 2005, the number of hospitalizations with this diagnosis increased from 3.3 to 4 cases per 100,000 people. Reasons. Acquired Quincke's edema often develops in response to the penetration of an allergen into the body, a drug, a food product, as well as insect bites and stings. The resulting acute allergic reaction with the release of inflammatory mediators increases the permeability of blood vessels located in the subcutaneous fat and submucosal layer, and leads to the appearance of local or widespread tissue edema on the face and elsewhere in the body. Quincke's edema can also develop with pseudoallergia, when hypersensitivity to certain medications, foods, and food additives develops in the absence of an immunological stage. Another of the causal factors contributing to the occurrence of edema is taking medications such as ACE inhibitors, captopril, enalapril, as well as angiotensin II receptor antagonists, valsartan, epirsartan. In this case, angioedema is observed mainly in the elderly. The mechanism of edema when using these drugs is due to the blockade of the angiotensin converting enzyme, as a result of which the vasoconstrictive effect of the hormone angiotensin II decreases and the destruction of the vasodilator bradykinin slows down. Quincke's edema can also develop with congenital, hereditary, or acquired deficiency of a C1 inhibitor that regulates the activity of the complement system, blood clotting and fibrinolysis, and the kallikrein-kinin system. At the same time, a deficiency of the C1 inhibitor occurs both with its insufficient formation and with increased use and insufficient activity of this component. In hereditary edema, as a result of gene mutations, the structure and function of the C1 inhibitor are disrupted. Excessive activation of complement and Hagman factor occurs, and as a result, increased formation of bradykinin and C2-kinin, which increase vascular permeability and lead to the formation of angioedema. Acquired Quincke's edema, due to a deficiency of the C1 inhibitor, develops with its accelerated consumption or destruction, production of autoantibodies, in malignant neoplasms of the lymphatic system, autoimmune processes, and some infections. Sometimes there is a variant of hereditary Quincke's edema with a normal level of C1 inhibitor, for example, with a familial mutation of the Hagman factor gene, as well as in women, when increased bradykinin production and its delayed destruction are due to inhibition of ACE activity by estrogens. Often, various causal factors are combined with each other. The culprit of allergic and pseudoallergic angioedema is the substance histamine, which is secreted from mast cells. Mast cells are present in most body tissues, skin, mucous membranes of the gastrointestinal tract and respiratory system, conjunctiva of the eyes, therefore. Edema can be of different localization. Allergic angioedema is a type Y immune reaction, Reagan or IgE-dependent type. After the first acquaintance with the allergen, food, pollen, animal epithelium, etc., antibodies, immunoglobulin E, are formed in the body of the allergic person. When the allergen re-enters the body, it interacts with the formed antibody. Because of this, mast cells become irritated and emit granules containing histamine and other inflammatory substances. This process is called degranulation. The release of histamine increases local blood flow and the permeability of the blood vessel wall. Blood plasma leaves the vessels, and edema occurs. Histamine also acts on special receptors on vascular and muscle cells, which causes itching and redness of the skin and mucous membranes. Histamine affects the respiratory, gastrointestinal, and cardiovascular systems. This can be manifested by narrowing of the bronchi, bronchospasm, with the appearance of coughing and suffocation, decreased blood pressure, loss of consciousness, vomiting, abdominal pain, loose stools, etc. The outcome of Quincke's edema depends on the severity of the manifestations and the timeliness of therapeutic measures. Thus, laryngeal edema in the absence of emergency care ends in death. Recurrent urticaria, combined with Quincke's edema and lasting for 6 months or more, is further observed in 40% of patients for another 10 years, and 50% may experience prolonged remission even without supportive treatment. Hereditary angioedema periodically recurs throughout life. Properly selected supportive treatment avoids complications and significantly improves the quality of life of patients with Quincke's edema. In case of an allergic genesis of the disease, it is important to follow a hypoallergenic diet, refuse to take potentially dangerous medications. With hereditary angioedema, it is necessary to avoid damage, viral infections, stressful situations, taking ACE inhibitors, estrogen-containing drugs. Diagnosis: a characteristic clinical picture typical of angioedema, localized on the face and other exposed areas of the body, allows for a quick and accurate diagnosis. The situation becomes more challenging when faced with symptoms of acute abdomen or transient ischemic attack, requiring differentiation from a variety of internal organ and nervous system disorders. It is even more difficult to distinguish between hereditary and acquired angioedema and identify the specific causal factor that triggered its development. A thorough collection of medical history helps determine genetic predisposition towards allergic diseases, as well as the presence of cases of angioedema in the patient's relatives without any identified allergies. It is important to inquire about cases of relatives dying from suffocation or frequent visits to surgeons due to recurrent severe abdominal pain without any surgical interventions. It is also necessary to find out if the patient has had any autoimmune or oncological diseases, and if they are taking ACE inhibitors, angiotensin II receptor blockers, or estrogen. Analysis of complaints and examination data often provides an approximate differentiation between hereditary and acquired angioedema. For hereditary angioedemas, slowly progressing and long-lasting edema is typical, often affecting the mucous membrane of the larynx and gastrointestinal tract. Symptoms often appear after minor trauma in young individuals without any connection to allergens, and antihistamines and glucocorticoids are ineffective. There are no other signs of allergy, urticaria, bronchial asthma, which is characteristic of allergies. Laboratory diagnostics in non-allergic angioedemas can reveal a decrease in the level and activity of C1 inhibitor, autoimmune pathology, and lymphoproliferative diseases. In angioedema associated with allergies, blood eosinophilia, elevated levels of total IgE and positive skin tests are detected. In cases of stridor breathing with laryngeal edema, laryngoscopy may be required, while abdominal syndrome may necessitate a thorough examination by a surgeon and the conduct of necessary instrumental investigations, including endoscopic procedures, laparoscopy, colonoscopy. Differential diagnosis of angioedema is conducted with other edemas caused by hypothyroidism, superior vena cava syndrome, liver and kidney pathologies, and dermatomyositis.